Hello everyone. A 27-day-old female baby admitted after 2 episodes of seizure. With the given images, what's the diagnosis and why the seizure? And hold on. If you want more time, please pause the video and reassess and have your probable thoughts. Think about your diagnosis. Are you ready? Let's go. The given images of the high resolution ultrasound of the pylorus, and they're almost pathognomonic for the diagnosis of hypertrophic pyloric stenosis. The measurements of pyloric length of 22 mm are already given, and the diameter of 13 mm and one wall thickness of 4.4 mm actually are not needed for the diagnosis because the thickness is so much, it's highly eye-catching. Now the second question, why the seizure? The seizure in early neonates, otherwise normal, who are otherwise normal, are usually due to hypoglycemia. But that can occur due to hyponatremia or hypokalemia or due to reduced calcium or phosphorus. But they were all here in this patient, in this baby, they were all normal. But in hypertrophic pyloric stenosis, as in this case, if the vomiting is severe and has been persistent for a longer time, hypochloremia is the first reason for seizure. Yes, the serum chloride was significantly reduced to 73 millimoles per liter in this baby. The baby had already undergone ultrasound abdomen 1 week back and reported to be negative for HPS. We will discuss about this, which is very crucial not only to the anxious parents and also to the involved pediatricians and pediatric surgeons. And we should not miss this diagnosis. This is the most common surgically treatable acquired gastric outlet obstruction in the neonates and in the early infants. The age is usually a range of few days to few months, but commonly 1 week to 3 months. Male to female ratio is 4:1. I mean, out of the 10 affected babies, almost 8 will be male babies. But remember, even female babies can also be affected, as in this our case. Clinically, vomiting is present in all the cases, and there will be 3 P's. First one, progressive vomiting. Second one, P is projectile vomiting. Third one is palpable mass in the epigastric region of the baby. So that's the 3 P's. But few parents might give the history of progressive and projectile vomiting even in gastritis, which is also very common. For more than 2 decades, the ultrasound has replaced barium meal to diagnose hypertrophic pyloric stenosis with linear high resolution probe when there is no or poor movement of the stomach contents through the pylorus up to the duodenum, and if the pyloric wall thickness is more than 3 mm, and if the pyloric diameter is more than 13 mm and the elongated pyloric length measures more than 18 mm, it is highly characteristic of hypertrophic pyloric stenosis. If the pyloric wall thickness is less than 2 mm during ultrasound, if the pyloric wall thickness is less than 2 mm and the pyloric length is less than 14 mm, it might be reported as either pylorospasm or early spasm of hypertrophic pyloric stenosis. When there is reduced or no movement of the stomach contents later, it's very important to mention in the report, please repeat if the vomiting is persistent and is becoming more projectile. That's what I usually do. So even if the patient, if it is due to pylorospasm, but if it becomes projectile later and again persistent, again a second scan will be very characteristically will be giving the findings of hypertrophic pyloric stenosis, so that we should not miss it any time. In the background of vomiting in the neonates, the common medical causes are GE reflux, which is very common. Gastritis is again very common in neonates. Pylorospasm, the next common one, and milk allergy. So these are the 4 common causes of vomiting in neonates. The 2 surgical causes which are very important for us to diagnose it on ultrasound, hypertrophic pyloric stenosis, and the second one is midgut malrotation. We'll go to the rare causes of atresia or stenosis in the pylorus or duodenum. Very rare to have focal foveolar hyperplasia or Menetrier disease in infants, but many articles have been reported. Nowadays, barium meal is not needed for the diagnosis, but for the academic purposes, sometimes barium meal sometimes becomes crucial to confirm this to the parents. I'll talk about the 6 signs of hypertrophic pyloric stenosis in barium meal. I am enclosing the picture so that this can be eye-catching to the postgraduates and residents. The first one is central beak sign. Second one is beak sign with adjacent concave indentation, which is called as shoulder sign. The third one is beak sign with gap and cap. See the image. Fourth one is string sign. Fifth one is longitudinal mucosal folds in the stenosis. The last one is again the longitudinal mucosal folds with tit signs in the edges, giving concave indentation in base of the cap. All right. Thanks a lot to everyone.